मैं खोल के देखता हूँ तो मैं खोल के देखता
So, ma'am, it's already sharp 9. With all your permission, can we begin? We are live.
Yes, dear, sure.
Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. She needs no introduction, but it's my pleasure and honor to introduce her at our platform. She's none other than Ma'am Dr. Ritu S. Antwani. She is the founder and CEO of 360-Degree Healthcare Studio and Shyam Well Women Clinic. She's an obstetrician and gynecologist and cosmetologist and infertility specialist. With the help of Ma'am, we'll be taking a close look on today's topic, which is pelvic inflammatory disease. Before moving on to today's session, let us have a brief look on what the topic says. Pelvic inflammatory disease is a polymicrobial infection of the upper female genital tract, the cervix, uterus, fallopian tubes, and ovaries. Abscess may occur. In some cases, infections contracted through sexual contact may result in PID. PID presents with lower abdomen pain, irregular vaginal bleeding, cervical discharge, etc., and can lead to ectopic pregnancy, chronic pelvic pain, and infertility in the long run. We'll be knowing more about the topic with the help of Ma'am. So now, without any further delay, I would like to welcome Ma'am at our forum and would like to hand over the session to her for her talk to begin. Ma'am, over to you.
Yeah, thank you, Batul. Thank you, IGCP Publications, for inviting me here. So, friends, so without wasting time, I am switching over towards today's topic. As we all know, these days are the auspicious days of the Navratri are going on, and today is the third day of the Navratri. And my all presentations always start with Mata Durga Stuti. And this is the evening time of Aarti time. So, Ya Devi Sarva Bhuteshu Chikitsa Rupen Sansita Namastasye 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 Namo Namah. So friends, today the topic which I am going to discuss with you all is the pelvic inflammatory disease. We all gynecologists getting lot of these kind of patients daily in our OPD. So whether the beginner or whether the well-established doctor, everybody is having this patients of PID in the OPD. So I am going to discuss regarding that. So we will take one by one. My topic will be covering these under these headings. How is the problem? What are the microbial causes? What are the risk factors? What are the clinical features? Uncomplicated versus complicated PID, diagnosis, differential diagnosis, treatment principle, management of complications, and management of postpartum endometritis. What should be given in the antibiotic prophylaxis? Monitoring and counseling, whether is it necessary to treat both the partners, and why to do the screening for the STDs in this. So we are taking one by one. So friends, as we all know, this PID comprises all the infections of the upper genital tract, including the endometritis, salpingitis, purulent pelvic fluid collections, and pelvic peritonitis of the genital origin. So here we can see the oophouritis, tubo-ovarian abscess, endometritis, salpingitis hydrosalpinx, pelvic peritonitis, and abscess, all are included in this. So if we can go through the statistical data, the disease is showing the one of the most common gynecological disorders of women all over the world. It is estimated in the age group of 15 to 25 years of young adults, PID occurs in 1% of the women around the world, 24 to 32% in India. The studies has been reported. In the developed countries, the annual incidence is to be estimated around 10 to 13 per 1,000 women, with 20 per 1,000 women being in the age group of 20 to 24 years. So now coming to the etiology, what are the common causes of this PID? So friends, as we all know, it has been divided the acute, subclinical, and the chronic pelvic inflammatory disease. So coming one by one to the acute pelvic inflammatory disease, when it is of less than of 30 days duration, less or 30 days of duration, the cervical pathogens, which are very commonly are attributing to this, Neisseria gonorrhoeae, Chlamydia trachomatis, Mycobacterium genitalium, the bacterial vaginosis pathogens, Peptostreptococcus species, Bacteroides species, Atopium species, Leptotrichia, Mycoplasma hominis, Ureaplasma urulaticum, and Clostridia species. Respiratory pathogens, the Haemophilus influenzae, Streptococcus pneumoniae, group A Streptococci and Staphylococcus aureus has been reported. While amongst this enteric pathogens, E. coli, Bacteroides fragilis, group B Streptococci and Clostridium species has been reported. Similarly, in the subclinical, the Chlamydia trachomatis and Neisseria gonorrhoeae are reported. While in the cases of the chronic inflammatory diseases, where it is of more than 30 days duration, the Mycoplasma tuberculosis and Actinomyces species has been reported. So we all know in our India, the commonest cause of this chronic PID is the tuberculosis. So now coming to the next point, that what are the risk factors associated with this? Age younger than 25 years, new or multiple sex partners, which is very commonly we are seeing these days, the polygamy, unprotected sexual intercourse, intercourse with a symptomatic partner, young age at onset of sexual activity, younger than 15 years, history of STIs or PID. Possibility of PID should be considered in any sexually active woman. Several studies have shown a relationship between a PID and bacterial vaginosis associated anaerobic bacteria. So now what are the clinical features by which we can diagnose? So friends, we all know sometimes the patients may be asymptomatic. Many women with tubal factor infertility have a histologic evidence of PID despite having no previous diagnosis. So what are the clinical features associated? Is the clinical cardinal symptom of the PID is the abrupt onset of lower abdominal or pelvic pain in a sexually active woman. Symptoms can be subtle with mild bilateral lower abdominal pain that worsens with coitus, abnormal uterine bleeding, increased urinary frequency, dysuria or abnormal vaginal discharge. Fever may also occur. And very importantly, the syndrome, the Fitzhugh-Curtis syndrome, we all who have gone through our MBBS Viva examination, this is a very, very common question. The Fitzhugh-Curtis syndrome, in which the patient usually presents with right upper quadrant pain that is worse with the movement. Breathing is caused by inflammation and adhesions of the liver capsules, such as in perihepatitis. So right upper quadrant pain, then which is worsened by the movement and breathing and the inflammation and adhesions of the liver capsule. These are some presenting symptoms. So friends, as the topic is very vast, I will try to summarize as much as possible. So in this, as we all are aware, it can be categorized into uncomplicated or complicated. In uncomplicated, the simple is compatible with outpatient management, while in intermediate, requiring hospitalization for diagnostic, uncertainty, symptom intensity, difficulties with oral antibiotics, previous treatment failure, or psychological distress, while in complicated includes the pelvic peritonitis, tubo-ovarian abscess, regardless of the size, with or without signs of severity, rupture of abscess, generalized peritonitis, and septic shock. Then the diagnosis of this PID is clinical, imaging and more invasive studies reserved for a diagnostic uncertainty or concern for complications. Diagnostic evaluation should not delay the treatment. So we are sending the mucopurulent swab for the culture and sensitivity. But meanwhile, we have to start the treatment because the culture report, as you all know, is coming after mostly after 5 days. So we can't wait for such a long time because the symptoms may more worsen by that time. So after taking the swab and culture, we can start the antibiotics. So here we can see the physician should make the diagnosis and initiate the treatment for PID if no other diagnosis is more likely in the sexually active woman younger than 25 years or in older women at a risk of STIs who present with the pain in lower abdomen or pelvis and one or more clinical findings. So friends, here we can say if the woman is sexually active or at increased risk of sexually transmitted infection. If yes, the pelvic pain or lower abdominal pain present. Then if yes, cervical motion tenderness, uterine tenderness, and adnexal tenderness present. Then yes, the other causes of pain has to be excluded. Then if yes, the pain, the treatment of the PID is must. In the cases where the pelvic pain or lower abdominal is not there, in that cases, the routine screening for the sexually transmitted infections is usually we advise. So, meanwhile, friends, those who have logged in, if you are having any questions, please put in the chat box. Later on, we can discuss all that. So, now how can we diagnose this? So, friends, as we all know, the main common symptom is the cervical mucopurulent discharge of friability, elevated C-reactive proteins, elevated erythrocyte sedimentation rate, larger number of WBCs on saline microscopy of vaginal fluid, oral temperature greater than 101 Fahrenheit, testing positive for Neisseria gonorrhoeae or Chlamydia trachomatis, increases the specificity of diagnosis, but this comes at the risk of decreasing the sensitivity and thereby potentially missing the cases of PID. So bimanual examination should be performed on all patients with suspected PID to assess for the cervical motion, uterine, and or adnexal tenderness, adnexal masses or tubo-ovarian abscess. Speculum examination should be performed to identify the mucopurulent cervical discharge. Saline microscopy of vaginal discharge may reveal the predominant white WBCs, which could indicate the coexisting bacterial vaginosis and trichomoniasis. Then in the cases, all the patients who are suspected of having PID should have a serum or urine pregnancy test to exclude the ectopic pregnancy. Then there are a lot of different new tests available, especially the screening with nucleic acid amplification test for chlamydia and gonorrhea. Pelvic ultrasound will not contribute to a positive diagnosis of uncomplicated PID because its sensitivity and specificity are both poor. It is recommended to look for signs of complicated PID or a differential diagnosis. Then abdominopelvic computerized tomography with contrast product injection is useful for the differential diagnosis of the urinary, GIT or gynecological origin. Laparoscopy is usually not recommended for the sole purpose of obtaining a diagnosis of the PID. So friends, here we can see how we can differentiate the appendicitis, ectopic pregnancy or rupture, endometriosis and endometritis. And we all know, especially in this endometriosis, the dysphagia, dysmenorrhea, intermenstrual bleeding, and dyspareunia. While in endometritis, acute fever, pelvic pain, vaginal discharge, chronic pelvic discomfort, vaginal spotting, and leukorrhea usually presenting symptoms. While in this ovarian cyst, rupture or torsion, the acute onset of the unilateral pain. While in this tubo-ovarian abscess, the fever, pelvic adnexal masses on bimanual examination, unilateral pain. While in ureteral calculus, dysuria, fever, nausea, vomiting, hematuria, and pain. While in UTI, as we all are aware, increased urinary frequency. Dysuria and hematuria are the usual presenting symptoms, and mid or bilateral pelvic pain. Again, the slides are getting stuck sometimes. Yeah. So friends, so these are the different how we are diagnosing. So now the treatment, coming to the treatment portion, the treatment should not be withheld until the STI testing results are known. Delaying treatment by 2 or 3 days from the presentation increases the risk of infertility, and ectopic pregnancy are nearly threefold. Antibiotic selection is based on the need for inpatient versus outpatient care. No difference in the pregnancy rates, time to pregnancy, PID, recurrence, chronic pelvic pain, ectopic pregnancy have been found in women with mild to moderate PID who receive the outpatient treatment. So usually with this mild to moderate PID can be treated in OPD basis, while the indication for IPD, for the admission in the patients there is intolerance to oral therapy, high fever, nausea, vomiting, intractable abdominal pain, or severe illness is there, or when surgical emergency cannot be excluded. The different regimens for this has been reported are the different therapies. What the therapies has been reported by the different guidelines. I am showing the slide by the CDC guidelines. The cifotatin, the 2 gram IV 12 hourly plus doxycycline 100 ml orally, 100 mg orally or IV every 12 hours, or cifoxidin 2 gram IV 6 hourly plus doxycycline 100 mg BD. Or the clindamycin. A lot of studies have now come with the role of the clindamycin 900 mg IVA over 8 hours plus gentamicin in a loading dose of 2 mg per kg of body weight, either intramuscular or intravenous, followed by a maintenance dose of 1.5 mg per kg every 8 hours. So this has been reported. While alternatively, the ampicillin and sulbactam 3 gram IV every 6 hours plus doxycycline 100 mg BD has been reported. There are so many different regimens which has been reported. Cifoxetine plus doxycycline, cifoxetine plus probenecid 1 gram orally administered, or doxycycline BD with or without metronidazole 400 mg orally twice a day for 40 days. With the metronidazole, the basic problem is the metallic taste, but these days a lot of food preparations with the extended release are available, so that are very good in results and less patient compliance. Then other parenteral cephalosporins, ceftriaxone or cefotaxime plus doxycycline 100 mg orally twice a day for 14 days with or without metronidazole 400 mg orally twice a day for 14 days has been reported. So while treating these patients, the some common points which we have to remember: patients may be transitioned from parenteral to oral therapy after 24 hours of clinical improvement. This is a very basic point. If the patient is having a symptoms of severe symptoms, then in that case, of course, we start with the parenteral therapy and switching to the oral therapy only after 24 hours of clinical improvement. Completion of 14 days of treatment with oral medications is recommended. Those patients treated with any of the CDC recommended inpatient regimens or with the alternative regimen should be transitioned to the oral doxycycline 100 mg every 12 hours. Patients treated specifically with clindamycin and gentamicin should be transitioned to oral doxycycline 100 mg every 12 hours or oral clindamycin every 450 mg every 6 hours has been reported. Similarly, the patients who are not ready for the IPD or do not require the IPD treatment, in that case, we can give the combination of the intramuscular and oral therapy. And the CDC guidelines currently recommending the addition of the metronidazole in all OPD treatment of the PID and in patients who have trichomoniasis, bacterial vaginosis, or any history of the uterine instrumentation. So, because of the emergency resistance, the quinolone use is no longer recommended for the PID treatment in providing the empiric coverage for the gonorrhea. So, for the pain, the different preparations are available with the combination of the drotaverine and mefenamic acid. A lot of studies have come in the favor of that. So, while in the coming to the category of the management of a complicated PID, the tubo-ovarian abscess, TOA, is larger than 3 to 4 centimeter, must be drained by imaging, guided puncture or laparoscopy. It is recommended that the start of the antibiotic therapy and TOA drainage should not be delayed once the diagnosis is made. Then transvaginal drainage is preferred to a laparoscopic drainage because of the feasibility is excellent and it can be performed from the outset with the simple sedation and repeated if necessary. So these are the some guidelines what they suggest. While in the cases of the complicated PID, the surgical management is to be envisioned rapidly after the probability antibiotic therapy has begun. The surgery must be performed by laparoscopy if possible, and drainage is preferable to excision. So, all the studies, all the new papers what I presented, all favor is a drainage instead of doing the excision. So, coming to this antibiotics. So, friends, the first line antibiotic regimen is the, as we have just discussed, the ceftriaxone. And until the clinical improvement together with doxycycline and metronidazole. So IV doxycycline and metronidazole should be replaced by per oral with the same dosage for the 14 days. Then coming to the management of the postpartum endometritis. So here the first line antibiotic therapy of postpartum endometritis combines the amoxicillin and clavulanic acid 3 to 6 grams per day according to body weight, IV or per oral. Usually, if the patient is having a excruciating pain, fever, we prefer to go for the at least for the 24 hours with the injectable, and the treatment should be continued until 48 hours after the fever is ended and the pain can no longer be induced. Usually, what happens once we give 1 or 2 doses of the injectables antibiotic, usually the patient start feeling better, but we have to continue the treatment till 48 hours after the fever is ended and no longer pain. So in for this also postpartum endometritis, the clindamycin and gentamicin is reported. Then CT or MRI is be done in the fever persist in spite of the appropriate antibiotic therapy prescribed for postpartum endometritis and look for the pelvic thrombophlebitis or the deep abscess. These studies has been reported. So for this PID prevention, antibiotic prophylaxis, yes, is administered. Alternatively, means either the cefazolin, cefuroxime. I usually basically prefer the cefuroxime, or alternative is clindamycin at a dosage of 900 mg per day, slow IV infusion for an hour with continuous surveillance of the maternal heat rhythm. There are a lot of studies in the favor of this. So this antibiotic prophylaxis is recommended in a female undergoing for the HSG if she has a history of PID, uterine evacuation for early pregnancy loss, and first and second trimester abortions, and not recommended for these small procedures like colposcopy, endometrial biopsy, IOD insertion, or endometrial ablation. Though in our practice in India, we are giving, whenever any type of the procedure we are doing, we are giving at least 2 to 3 days of the antibiotics. So now what about the recurrence? Yes, the disease recurs in 15 to 21% of the women. The recurrences are linked to a substantial infection rate, 20 to 34%. and increase the risk of infertility and chronic pain. Follow-up of women with STI reduces the infection rate, and it is recommended the follow-up is after PID associated STI is recommended. Several studies have shown that the PID and bacterial vaginosis associated with anaerobic bacteria. Then microbial examination of by this NAT test of Chlamydia trachomatis Neisseria gonorrhoeae of a vaginal sample 3 to 6 months after a treatment of PID has been associated. So there are a lot of studies in the favor of this. While it is important that for the monitoring and counseling after the treatment of the episode of the treated PID, usually some patients give us the history that, ma'am, we can't insert the IUD again. Last time we suffered from the PID, but it is not like that. That IUD insertion is not contraindicated. In the females with the history of PID, the microbiological examination by NAT, Chlamydia, trachomatis, gonorrhea, and genitalium of the vaginal swab is recommended before and at the moment of IUD insertion. So friends, this is the important points: trachomatis, Neisseria gonorrhoeae, and Mycoplasma genitalium. So, so the females who want to conceive after the PID are warned about the risk about the ectopic pregnancy. So, an epidemiological association occurs between the history of PID and serous ovarian carcinoma, which the relative risk is modest, 1.2 to 1.5, and no causal link between the PID and ovarian cancer has been demonstrated. So these are the different studies has been presented for this PID. The topic is so vast, I'm trying to summarize. So how to treat: abstain from all the sexual activity until they keep and their partners are fully treated and symptom-free. Use of condoms is recommended after PID is associated with an STI or reduces the risk of recurrence and sequelae as long as the STI risk factors persist. Patient should be counseled on the complications of PID and the need for safe sex practices and the risk of having multiple sexual partners in PID recurrence. So this is also very, very important. So again, the studies have shown the patients who had a sexual contact within 60 days with a woman with a PID should be offered for STI testing and treatment. Then the studies have shown approximately 20% reduction in the chlamydia prevalence and 50% reduction in gonorrhea at the follow-up is used. So gonorrhea treatment is limited to oral options. So we can give either cefixime 400 mg single dose or azithromycin 1 gram single dose has been reported. Though sometimes we have to adjust the dose depending upon the clinical parameters of the patient. So along with the medicines, we have to recommend for the STI testing, safe sex practices, sexual abstinence until both the partners have complete therapy and symptoms. So friends, as you all are aware, so for screening for this bacterial vaginosis, Chlamydia trachomatis, Neisseria gonorrhoeae, all has been reported. In all these, because of these infections, the normal lactobacillus is decreases, which is helpful. Which is helpful for combating the viral infections. So if these infections are present, decrease epithelial exfoliation, decrease in polyamines, and a decrease in flu cells bacterial, decrease in vaginal discharge, and unpleasant odor has been reported. Last few slides are there. So different studies have shown that by giving the probiotics in these will be very, very useful. So studies have shown the lactobacillus strains such as Lactobacillus acidophilus have shown to promise the improvement of vaginal symptoms and redness in the patients of yeast infections. So again, the new drug has been come is the fenticonazole, which exerts an antimycotic mechanism of action, which is having a very, very good results. The mode of action is either by inhibition of the secretion of protease by the Candida albicans, damage to the cytoplasmic membrane, and by blocking the cytochrome oxidases and peroxidases, exhibits the antibacterial action with a spectrum of activity which includes the bacteria commonly associated with superficial fungus, skin, and vaginal infections, and antiparasitic action against the protozoan Trichomonas vaginalis. So a lot of the studies have come regarding the use of this fenticonazole, and the drug is having a very good results. So with this, either by the intravaginal administration also, a lot of studies has been reported. Then for this fungal infections, we are giving the itraconazole 200 mg/d for 3 days or more. The success rates is means as effective as oral oral fluconazole and topical clotrimazole. So friends, we all are aware that these drugs we are using very commonly. And in some studies, the single dose of itraconazole 400 mg has also been reported. So these are the different trials, different studies has come with regarding the favor of the use of the itraconazole too. Then a very recent drug, a very important drug is a luliconazole. So I thought, yeah, I must insert these 2-3 things in my presentation. So luliconazole, as we all know, inhibitor for esterol 14 alpha demethylase in the fungal cells. Then luliconazole has been clinically associated with the pityriasis versicolor, dermatophytosis, onychomycosis, cutaneous and mucocutaneous candidiasis has been reported. So now one more recent drug has been reported. It's a fosfomycin, the broad spectrum antibiotic. So a lot of studies have shown that there's high tissue penetration, and it can go through the tissue targets and tissues and targets, including CNS, soft tissue, bones, lungs, abscess. So it is a multiple dose regimen. So it has emerged a potential strategy for treating the complicated UTIs. So friends, in the yes, lot of studies with the use of the fosfomycin, usually the single set should be advising. So before I wind up these 2-3 slides, so the diagnosis is very important. Then empirically antibiotic treatment should be offered. Female with mild to moderate PID can be treated in an outpatient setting without an increased risk of sequelae. And the annual screening for all these sexually active females, it is recommended for chlamydia and gonorrhea. So long-term sequelae, friends, as we all know, is a chronic pelvic pain, infertility, ectopic pregnancy has been reported. So prevention is by monogamous relationship, early onset of sexual intercourse, and avoidance of high-risk behavior has been reported. Then lot of studies have come that the health education and sex education is very, very important. So, so thank you, dear friends, for your patient hearing and for your interest and your time. So if there are any questions, so we can discuss here. Because PID is such a vast topic, so can't be covered in one lecture because it has to elaborate it. Have to elaborate lot of things. Though I tried my best to summarize this in half an hour, but still I can understand that lot of points we can't cover in this half an hour lecture.
Thank you so much, ma'am, for such a wonderful insight that you have shared upon the topic. And definitely, like you said, the topic is so vast, we cannot cover, but yet in such a short period of time, you have done complete justice to the topic by your wonderful presentation. Thank you so much for that. We have received few questions and I would like to put it across to you. The first question is, what factors influence the degree of inflammation that occurs in PID?
I already covered. May I know the name of the doctor who has asked this question?
It's Dr. Gitanjali.
Yeah, so yeah, Dr. Gitanjali, hi. So see, already I have put all these slides. Maybe you have joined late. Yes, the decreased immunity, lack of sexual hygiene, and the polygamy. These all are predisposing for the degree of inflammation, and the repeated sexual intercourse with the infected partner also promotes this. So if you can go through the presentation, you will get these answers automatically. Yeah.
Thank you so much, ma'am, for answering the question. We'll move to the next question that we have received, and this question has been asked by Dr. Namita. Dr.
Yeah,
Namita
yeah.
wants to know how frequent is tubo-ovarian abscess in women with pelvic inflammatory disease, and how does it affect the disease of course?
See, tuber-ovarian abscess, the incidence has been reported approximately 3 to 5%. So if the how it comes, the output, yes, that all depends that you are treating the patient of which age group. If the patient is on the childbearing age group and the patient's main concern is the fertility, then in that case, it's a prime importance that as early as you can treat this tuber-ovarian abscess will be the must. Because unless and otherwise this abscess, the discharge of the pus may block the tubes also, and then later on it create a havoc for the patient to get pregnant. Yes, if the patient you are getting of the age group of 55 60 years, in these patients also we are seeing these days of tubo-ovarian abscess. So in that patients you can do it conservatively by the medical treatment only. But if the patient of the childbearing age group, and if you're finding the patient is not responding to the IV line and the oral treatment also, in that patients the drainage is must.
Thank you so much, ma'am, for answering this question. We'll move to the next question that we have received, and this question is by Dr. Singh. Dr. Singh wants to know, according to the CDC guidelines, when is empiric antibiotic therapy indicated for the treatment of pelvic inflammatory disease?
So that I have already shown. He can go through the slides. I have already shown all the criteria from the CDC.
We'll move to the next question and the last question for today's session. And this question is by Dr. Kumar. Dr. Kumar wants to know which infectious agents are more common in women with pelvic inflammatory disease who use IUDs.
Okay. See, these days, yes, earlier the history of that with this E. coli and bacteroides are more. But these days with the patients with the IUD, also we are seeing lot of patients with the chlamydia trachomatis, Neisseria gonorrhoeae, mycoplasma, ureaplasma urinaticum, herpes simplex 1 and herpes simplex 2. So these 8 bacteria and are we are getting very commonly these days in the patients with IUD. Earlier the histories have shown, all the incidents have shown only the group B streptococcus, but nowadays a lot of new guidelines have come, lot of new studies have come, and all these we are doing the study of all these 8 because we are doing the one STD panel in this where we are studying all these 8 kind of bacteria what I have mentioned now, bacteria and viruses.
Thank you so much, ma'am, for answering all the questions. That was the last question for today's session. And at the outset, I would also like to thank all the viewers who have joined our platform for the knowledge that has been shared by you and for sharing their valuable questions with us. And alongside, I would also like to thank you, ma'am, for your valuable time and for your valuable insight that you have shared. We hope that the insights that you have shared must be helping the doctors in their daily clinical practices. So thank you so much, ma'am. Thank you for that.
Thank you, dear Batul. And like these, many more informative videos are already uploaded in my YouTube channel also, in which we usually discuss the academic discussions. Those who want can see on my YouTube or my Insta channel also. A lot of academic videos are posted. Yeah, anyhow, thank you, dear. Thank you, Batul, for inviting me here. So we will wind up with this today. Yeah.
Thank you so much, ma'am. We are concluding the session here for today.
Yeah. Okay, dear. Bye-bye. Good night.